So I'll wait till you hit the record, and we are recording. All right, ladies and gentlemen, this is April 14, 2020, and we have our very own Brian Daniels today. He is the Director of Clinical Education for Respiratory Therapy here at Skyline College. He has over 30 years experience as a respiratory therapist. So you started when you were about 5 years old, right, Daniel? Brian, sorry. Well, anyways, I will let you go and tell your story then.
Okay. So good afternoon, everybody, early evening. I'm actually delighted to be here speaking with you regarding this very sensitive and horrific pandemic and crisis that we're having here with this coronavirus. I, in fact, am apologetic that my camera on my computer is not working, but I guess my computer knows that I'm camera shy, although I was planning to make myself visible to you and maybe even show you some of the PPE that we don and doff here in the wake of all this. As Dr. Cap mentioned, I am a professor there at Skyline College. It's one of the most delightful things I get to do week in and week out, while at the same time still being able to be a practicing clinician in respiratory care. And even more exciting, I'm a clinical researcher here with the University of California, San Francisco, and have had some very nice and exciting opportunity to work with other disciplines, scientists like you all are budding to be, engineers like many of you are budding to be. And so really, I think this is a very nice opportunity to share some of the things that are being done. And certainly, hopefully someone will monitor the chat. I don't want to spend all of the time talking. I want to be able to allow some dialogue and maybe some Q&A. So I'll try to move through most of this pretty quickly. I do have a slide set that I'll go through because I think it's important to lay a little bit of foundation before we start talking about what we are doing and have done here in the Bay Area with regards to COVID-19. So I'm going to go ahead and share my screen. And we want to go here to slideshow in the beginning. Okay, so I want to kind of start out by just going back to the origin of COVID-19 virus disease 2019, which started in Wuhan, China. And I looked at some of these pictures and I thought it was beautiful.
Brian, can you get a little bit closer? You're fading out again. Brian, you're starting to fade out again.
Can you hear me now?
A little bit more. Try it again.
I'm right here. I'm just looking at my phone. Can you hear me now?
It's still kind of fuzzy. Where were you at before? Are you moving around?
How about now? Can you hear me now?
It's still a little bit weak.
My cell phone in my lab here at UCSF. Let me see if I can transition to a landline. Okay.
All right. All right, Brian, we're ready to go.
Okay, good. All right, so let's go to the next slide. And so again, just for some geography, you can see exactly where Wuhan is located in China. Again, it's a small area there. China in and of itself is not very big, but again, this is where it all started. And then just to kind of take you on a journey the first case was diagnosed close to a seafood market on December 8th, 2019. And you can kind of see the progression, and we'll kind of walk through this a little bit just to kind of give you some insight on what happened. This is basically the market area where the first case was diagnosed. And then by January 11th, there was a spring festival that started out there as well. So you can see the people congregating in the area again, which also is all a perfect setup for something as infectious as a disease like this has shown us to be spread to larger areas. And then, of course, once it was confirmed on January 20th that there was human-human transmission, and this is some information that we fortunately here at UCSF had a colleague that was right there in the midst of all this, who was actually sharing some of this information with us about COVID-19. And then there was also a suggestion of lockdown. And the reason why this is significant is because as the pandemic started to move globally, there were individuals that suggested that there should be some sort of quarantine measures put in place and lockdowns to really get a handle on this rapidly spreading disease. And then by January 23rd, they did indeed have this lockdown, and where they started to do what we are considering here a shelter-in-place type of ordinance. And then, of course, by February 2nd, this thing, as you can see by the chart here, had started to spread amongst large numbers of people that they actually had gotten to a point where hospitals had become overwhelmed, and now you had these mobile cabins and setups and arenas for sheltering and caring for patients who were confirmed COVID positive. Again, I was talking to a friend of mine who had a colleague who was 28 years old who contracted COVID-19 and died from these overwhelming complications associated with the respiratory tract. And we can talk a little bit more about how the disease manifests in the body as we go through. By this time, in February, they were already running short on supplies, and they were taking donations from other countries who were yet to note that they would be experiencing some of the same things. I think one of the best things that they did was to try to change the trajectory of this, was to have some sort of intervention for preventing the spread, like the sheltering in place. The other thing that was really key is the mask, everybody in a mask concept in that region, not just the people who might have been presumed infected or exposed, but also those who had no exposure and certainly no symptoms of having COVID-19. By doing this, the trajectory changed. This could, in other words, have been a whole lot worse than it was. This is when they put in the lockdown procedures and they had everybody kind of quarantined in their homes, what happened to the trajectory. And so again, very important, especially given our situation here in the United States. So this is the global effect. Right now, when you look at the number of cases, we're now, as of noon today, this is the most there's probably more recent data now or information, but we have almost 2 million confirmed cases globally, with 500,000 of those almost have recovered. But again, 125,000 deaths. Now, interesting, that is still under 1%. So one could argue that even though this is a very lethal disease, the number of people who are dying is still probably less than those who die from the flu. But again, you can see how it is overwhelming the world. And you can see the darker the color in this map, the higher the number of confirmed cases, and usually what comes with that is a larger number of deaths. And you can see the United States where we are in terms of color shade. And if we look at us on this, just isolating us, and I'm actually proud of our mighty state because we were one of those who took this serious enough to implement the shelter in place and social distancing early. But again, if we just look at our country, we're well over 500,000 cases already, with almost 26,000 deaths really in this country. With almost half of those deaths are in the New York City area. And, we probably all have talked to people. We have friends there, and they can tell you how horrific that is, not just for the number of folks that are dying, but also thinking about the number of places that are without supplies. I'm a respiratory care practitioner, and right now respiratory care practitioners are in high demand in that region, but there are folks that are going there with the good intent of supporting patients and the effort to take care of those who are seriously ill with COVID-19, but they get there and things are in such a disarray, and the lack of personal protective equipment that a lot of them have gotten back on planes and came back home for fear of their own safety. And so again, it is really impactful there. Some of you have watched the news and you saw the number of deaths that have happened to the point where they're putting the bodies in trenches. And I think that is just really heartbreaking to hear that. And so again, what can be done? And again, California, if we look at us on this list, at one point, California was next to New Jersey in terms of the number of confirmed cases and deaths. And now California has slipped to number 6. And we've been overtaken in the last week and a half by Pennsylvania, Massachusetts, and Michigan in terms of number of cases. And so we're doing very well here. In fact, honestly, we are actually seeing the curve flattening for us here in California, which means we'll reach our apex probably sooner than we anticipated, and we'll start downward. If we zoom in on California, and again, this may be data that you're already familiar with, but we look at us here, most of the confirmed cases are in the Los Angeles County region, and all I did was put them there kind of as a marker as being the place that has the most confirmed cases and the largest number of deaths. But if you look at the Bay Area, you can see here, and for a long time, Santa Clara was the second in this state in terms of confirmed cases of COVID-19, and of course then deaths. And so we're seeing that now Santa Clara has been passed now by San Diego in terms of high number of confirmed COVID-19 cases. But I believe, again, that we took some significant measures to try and mitigate the spread of COVID-19 in this area. And we'll talk a little bit more about that. So a couple of take-home messages, because I want to go back to Wuhan's experience and talk about some take-home messages that I believe were helpful for us, and talk about some of the other things that we're doing to manage this. Take-home message number 1 is locking down and traffic bans, keeping people at home, quarantine, was helpful, but certainly not enough. There were other things that needed to be done. And I think that was timely. When you think about the transmission, family transmission is common because, again, you come together, families spend more time together probably than some friends, arguably. And of course, you're going to have a higher chance of contracting COVID-19. The other thing is, again, when you look at cases in the communities, where, again, folks that cohort together, maybe not just family members, but other close contacts, including, places like gyms and churches. I mean, I look at the number of people who work out at the gym who end up contracting MRSA. Again, you think about it, all the measures that were then put into place to wipe down equipment, but you could see how fast, it just was something that wasn't highly publicized, but that runs rampant through gyms. And then, of course, the challenge for infected cases to seek medical care. I'll tell you that one of the first cases at one of our local hospitals that ended up in an intensive care unit for 4 weeks was a person who was delivering pizzas who actually stayed home for 10 days not feeling good before they finally went into the hospital and declared themselves not feeling well, was tested and was COVID positive. And they spent 4 weeks in the ICU on a mechanical ventilator, fighting for his life. This was a 49-year-old person. And then, of course, just something to think about, and it is truly an honor system. It's difficult to enforce cases to stay home. You might remember the decree that your governor made a while back where the folks were still going out to the beaches and hanging out, and finally he started closing that down. And you probably noticed that in your own communities where you might have still decided to go out and go to the park, that at some point you saw them chained and roped off to keep people from cohorting together or crowding together in the wake of this COVID-19 pandemic. And again, so these traffic bans, the social distancing, the home quarantine, it does lead to a significant reduction in the spread, but it's really not enough. And we need to talk about that a little bit later. I love the experience here. Some of you might be familiar with Amy Proal's experience, but she shared publicly her situation of becoming critically ill and unstable with COVID-19 back in February, and she described her symptoms of feeling very sick with this COVID-19, including a high fever, and acknowledging that her boyfriend got sick first before it happened to her. Again, just confirming that being in close proximity in your circle, if you will, of individuals and not knowing, who might be infected with this. And so again, if you look at her experience, it illustrates a lot of these things, these social norms that put us at risk. But again, her case is typical, illustrates the issue with home isolation. Because, she took it serious, but again, the folks that still come over and visit, she had the symptoms on the 21st, then her boyfriend had the symptoms first, and then she had it. Both, unfortunately, could not get tested, so that's another issue that is problematic, is having enough kits and enough resources to be able to test. And again, now think about it like this. This boyfriend who was infected then went to see his internist with no mask, because that was prior to some of the more aggressive measures being put into place. And so you can see how this could spread, very quickly from one person to another. And then, of course, thinking about then the doctor, certainly on the way to the doctor, now catching public transportation. Let's go back to the gentleman who ended up in a critical care unit in the Bay Area who was delivering pizzas. How many folks did he come in contact with before, he declared himself and ended up in the hospital? And then, of course, if you're taking public transportation, even here in the Bay Area, which I noticed that, not very many people are riding public transportation, which is a good thing. And then, of course, the medical staff in the clinic. What about them? Were they fully protected at that time? I can tell you in our institution here, we only started implementing the double mask donning only a little bit over a week ago. And that means that when a person enters a medical center, they're screened and they have to wear a mask for the duration of being in the medical center. And that's even if you screen negative or if you have no symptoms. And again, I really believe that this was the important step that Wuhan, China took, of all the people wearing masks, whether they were infected or not, because you just never know. There may be folks that are asymptomatic that are out there and have been exposed. And then, of course, the doctor then had him go to the pharmacy, the CVS, to get medicine, right? Where then he would more likely infect the folks in that circle. So, I mean, these things are very important, especially considering that those who have significant comorbidities are certainly at high risk of being exposed and suffering a catastrophic event from having it. So again, if you look at the reports of infections using centralized quarantine after February 1st, 2020, you can see that if the quarantine continues, if this intervention continues, you can see how dramatically of a turn that this issue of COVID-19, this pandemic, would take. So it's very important. And I think this is why in California, when we look at our curve flattening, this is one of the things that we think about here. Some other measures. So again, just kind of going back and reviewing these quarantine measures that was put in place in Wuhan, which if you look at their incidence of COVID-19 spread, they have somehow attenuated significantly the spread. And these are just some of the things and thoughts that we have here. The home quarantine, the general traffic suspension, the social distancing, and again, keeping groups small, the control of frequency of shopping and going to grocery stores. As you know, all of these things are closed in our area. Healthcare workers who treat patients in these places, whether it be a designated hotel, a ship, or some other medical facility, or at least designated facility. You can see how they keep them away from, they keep the folks from transmitting, or put into place the proper PPE to avoid transmission of this illness. And again, they even looked at and took the experience of folks who were wearing full-on personal protective equipment and tracking them as well to see would they indeed contract COVID-19 by caring for those who were infected, and found that these folks did not become infected by it. So under centralized quarantine, again, keeping people from crowded areas. Now, when you look at some of the places in this country that have been hit hardest, it's places where mostly urban, for one, and again, places where there's crowding of people. New York was a perfect setup to have one of the worst outbreaks of COVID-19 of any place in the union, because small area, lots of people. and lots of people from different backgrounds. And so that was no surprise. And again, patients being able to receive medical care immediately, that's a game changer. We've seen that in my facility of identifying these individuals quickly, and of course, taking the mild cases and managing them before they become the severe cases and more difficult to manage. And again, taking folks and then again, managing them and monitoring them closely, and also not just them, but also those that are surrogate to them or their significant others and others in their circle, to have them tested promptly. And then, of course, if you look at patients who progress to, I guess, more severe or are starting to show early symptoms that were not turning or attenuating from measures put in place, these patients were transferred in a timely way and managed in intensive care units with more aggressive measures and not waiting until it becomes significantly life-threatening. You know, also, one of the things that we did here is we put in measures to, and this is a tough one, to avoid visitors to the hospital. In other words, as much as family members want to come in and see their loved ones, that was basically put on hold and shut down even to avoid, folks that might have contracted COVID-19 from that same family member now bringing it into the hospital and spreading it in this setting. We found novel ways to allow family members to be able to see their loved ones via telemeeting, kind of like we're doing here with Zoom, and teleconferencing, of course, on the phone for those who are not so severe that they can't be on the telephone or on a Zoom conference speaking to their loved one. I want to move now to the issue of screening and identifying these the presence of COVID-19 early. And again, this is also a game changer. And we know that probably some of the spread of COVID-19 could have been avoided or certainly mitigated by having supplies to be able to run tests on these individuals and increasing the testing capacity, which was also important. What I want to do now, that's kind of just a little bit of a background story. But now what I want to do is I want to kind of really now talk about our experience here in the United States, and specifically here in California in the Bay Area. And yes, we've put in shelter in place, avoiding social gathering, quarantine measures. Yes, we've done those things. Yes, we have more testing kits. Yes, we can turn tests around sooner to be able to know who actually have COVID-19 of those cases suspected. Yes, we are now donning PPE early, and we're not just protecting ourselves, but we're protecting our communities when we're coming into the hospital and leaving the hospital. Yes, we have cut down crowding and congregating just again to be able to control this. But what are we doing about those individuals who are sick? When you look at those patients who they had to dig a trench for in New York who died from complications associated with COVID-19, what are we doing about those individuals? And what really is the cause of death? Well, here is the interesting piece. COVID-19 is really an upper respiratory type of infection. COVID-19, the coronavirus, as many of you know and your professors know, is really the same virus or similar virus that causes the common cold. There are 7 coronaviruses that have been identified, but only 3 of them have been known to affect humans. The other ones have been known to be present in animals. And these are SARS, which you might remember from early 2000, and then there was MERS, which is a Mediterranean version of SARS, and then there's now SARS COVID-19. And again, even when you look at SARS, which is probably the grandfather to this particular strand of coronavirus, it was probably more lethal but arrested sooner than COVID-19. There's a lot of hypotheses on how COVID-19 actually developed. You know, where did it really start, even in Wuhan, China? That's a whole nother discussion we could have maybe in another open forum. You know, there's conspiracies, there's fact, there's fiction, there's everything out there to suggest how this thing started. But what we do know that it's an upper respiratory type of illness, but then somehow it could potentially lead to some sort of effect in the lower respiratory tract. It's been thought to be a pneumonia that develops, but I can tell you that when we look at some of these chest x-rays, they're not as remarkable for a lower respiratory tract infection as we would suspect, given the severity of them being able to get oxygen in their airway and across to their bloodstream and out to the rest of their organs. And so a couple things kind of resonate is, why do these patients have such a severe oxygenation defect? In fact, a lot of these patients' symptoms look like somebody who might have climbed Mount Everest, and they're up there. They can breathe, their lungs appear to be normal functioning, but they just don't get enough oxygen crossing their alveolar capillary membrane into their bloodstream. And so a couple of now new hypotheses is that maybe it could be that the oxygen defect is not at the lung-blood interface, but it might be related to the hemoglobin molecule and its ability to be able to bind oxygen and move it that way. So that's something that we here at UCSF might even be studying. In fact, there are a couple of scientists that are looking at the presence of iron levels, and seeing, you know, how does the body use iron? What other inflammation might be going on in the lung that might be making this ability to breathe and get oxygen in? Because people breathe harder, as you know, when they cannot get enough oxygen in place. The management so far for that can be anywhere from a person sitting in a regular hospital bed. Oh no, excuse me. Let me go back further. It can be anywhere from a person just quarantined at home that's COVID-19 positive, to a person then in the acute care setting just wearing a little bit of oxygen, or maybe not, just being monitored, to a person now requiring some sort of aggressive oxygen mask on, and even some sort of positive pressure applied to their lung, or a mechanical ventilator breathing for them and delivering high concentrations of oxygen. So there's a spectrum of patients that you see affected by COVID-19. Some of you who know, you may have antibodies against it and don't even know. Others of you could be COVID positive and may be asymptomatic. This is why shelter in place is important, because you feel good don't necessarily mean that you are COVID-19 free. It just means you may be like Tom Hanks and his wife, and you're just sitting at home, you know, just sheltering in place and just waiting for the symptoms to subside, and that you now build up antibodies and you're really not infectious anymore. Or even Idris Elba, some names that you all might know in some of these big movies. These are people who are affected, but they're not hospitalized and fighting for their life. The patients who usually end up fighting for their lives are the ones that have other things wrong with them. Like they have, in addition to COVID-19, they have high blood pressure, they have heart disease, they have diabetes. These are all things that could make a person who develop or contract COVID-19 at a point where they require a mechanical ventilator, which in some regions like New York are now scarce. The other thing that we are thinking about for them, there's a couple of medications that we are trying. Certainly there's an antiviral agent that we're looking at giving patients to see if we can attenuate some of these symptoms and maybe get the virus weakened. It's very hard to take care of a virus like COVID-19, or even just viruses in general, just because there's the treatment for them, or trying to find the right treatment for them, are a struggle. The other thing, and I don't know if any of you are taking courses where you're looking at some of these agents that are being used for managing COVID-19, maybe even in your microbiology class. I don't know if you are talking about any of these things, but remdesivir is the one that is being used in the hospital. In fact, it's being studied to see if it does have some benefit in attenuating the symptoms of COVID-19. The other one that is actually very attractive, believe it or not, and it's an anti-malarial drug, is hydroxychloroquine. This is one that we are also going to be looking at. It's really, again, it's used to treat malaria. It has been used to treat patients with these autoimmune disorders because it does have anti-inflammatory properties, but it also has a property, interestingly enough, that deals with this free iron that could be a culprit in patients who have some of the worst outcomes. So stay tuned for that, because that could be coming. There are also trials that are looking at things like vitamin C. You can barely find that in the store now because the word is out that vitamin C could be protective against coronaviruses in general, and perhaps it'll be protective here. I'll tell you one of the best kept secrets, and something that people don't do, and this is one of the things that I credit myself for not getting the common cold every year, and maybe, knock on wood, I'll be able to avoid getting COVID-19 is zinc. I do zinc on a daily basis. I think there could be some merit to using that to be proactive and preventative. So things like that are being looked at. And there's a couple of other clinical trials that are looking at some outcomes in COVID-19 patients, including giving mesenchymal stromal cells to patients with this, because one of the things that happens is they can get this rogue inflammation at the lung level, and they can get something called the acute respiratory distress syndrome. And that already carries a significant mortality. I've been studying ARDS now for the last 25 years plus. And there certainly are mechanisms in place to be supportive of patients. But again, to find an actual cure has been difficult and challenging. So I'm going to stop there because I do want to allow some time for question and answer. We're hoping that our curve will stay flat. When I look at the trajectory of this COVID-19 spread in our mighty state and in our country, this morning, the curve actually looked flat, and it remained flat for a good period of time. But just since we've been talking, the curve is now starting to slope upward again. And now the total number of cases at this moment is 611,923 cases with 25,701 deaths. And when we look at California, somehow Pennsylvania was number 5. Well, California is now number 5. And so really looking at this is almost like looking at the stock market when things started changing for it. You just cannot watch it every minute. Otherwise, you'll just claw your eyeballs out by the end of it all.
Awesome. Thank you, Brian. I just wanted to parrot some of the questions that came up in the chat. We have one that Bulk requested, a couple of questions. First, as a respiratory care practitioner, what is your specific role in the hospital? Do you work with nurses and doctors to come up with a plan of action? And I'll hold off on the third question after your response to the first two.
Okay, so respiratory care practitioners, formerly known as respiratory therapists. We're licensed allied health personnel who work fairly independent of any of those disciplines of question, physicians, nurses. We are certainly our own subspecialty. However, we do operate under medical direction. So respiratory care practitioners and respiratory care services will have a medical director. Our role is really cardiopulmonary health. So we are the guys that might do something as simple as see an asthmatic when they come into the emergency room and give them a breathing treatment to make that better, understanding what that breathing treatment is going to actually do to the airway to allow a person to breathe more comfortably, from doing anywhere from that to doing pulmonary rehabilitation, people who have chronic respiratory illnesses, teaching them how to live with chronic obstructive pulmonary disease or COPD, to taking patients who are post-op and helping them take deeper breaths when they're in pain so that they can not end up developing pneumonias or even losing lung volume and not being able to get the amount of oxygen, again, transferring to their bloodstream. 2, then taking care of patients who end up on what most people call life support machines, but these are mechanical ventilators. And again, we are the ultimate consultants when it comes to monitoring and managing lung conditions in patients who require this intervention.
Okay. Thank you. I'm going to ask one more question from the same person, but I just want to encourage everyone to feel free to chime in with a question or post it into the chat. We'll make sure to forward it to Brian. To finish off this last question, it's a bit more specific. Do you see the patients having smaller red blood cells because hemoglobin can't bind to O2?
It's not that and that's a great question. It's not that the red blood cell gets smaller per se, but for whatever reason, now the 4 sites that oxygen can bind to on the hemoglobin molecule, for whatever reason, is not accepting or binding that oxygen. So the oxygen is out there. In fact, some of these patients, believe it or not, we're giving them 100% oxygen. But then when we draw blood from them and we measure what is the oxygen or partial pressure of oxygen in the blood, it's very low. And again, this is something we don't quite understand, and we're trying to learn more about that.
Awesome, thank you. I have actually a personal follow-up question. At the beginning of the call, you were talking about how you collaborated with a variety of disciplines and professionals. Considering that STEM is interdisciplinary, can you just kind of mention some of the varying types of professionals that you work with on a day-to-day that would have a STEM degree?
Yes, and this is a question I'm glad that you're asking, Brian, because we would not be in the decent shape that we're in now with this COVID-19 pandemic if we did not have an interdisciplinary approach to managing these patients. Be that a physician, that's who my contact is in China, who's giving me a lot of information and a lot of origin of what happened there. Be it a former physician colleague and friend who is now in New York in the midst of this, working at one of the hospitals that has some of the most cases of COVID-19 patients, to talking to RNs who are on the front line and them sharing their experience, to talking to pharmacists, dietitians. I mean, it truly is a interdisciplinary approach. And to now talking to engineers and people who are in biotech, who are talking about how to come up with some of these different medicine preparations to how to get them absorbed faster in the system so that they can start working sooner, because there are a cohort of patients who actually decompensate very quickly. And so it really is a lot of folks, a lot of disciplines putting their minds together to come up with the best plan.
Perfect. Thank you. We just had one more question coming up in the chat. Just out of curiosity, what is the success rate of a patient that has been placed on a ventilator from your experience?
Very good question. So here I can share my experience, because the experience has varied from place to place. Here at UCSF, we have probably had a total of 18 patients placed on mechanical ventilators. We've had a total of 30 cases that have just remained in the acute care area, and over 600 people who have just been sent home after being screened, found positive, no symptoms, just go home and shelter in place, quarantine in place, I should say. But we have not had any patients who have been on mechanical ventilators suffer a bad outcome related to COVID-19 infection. We had one case of a patient who was on a mechanical ventilator who died, who was an elderly patient, and the family's wishes was to withdraw support. And so I think the success rate here is very good. And when you look at the number of people who are dying, it's less than 0.5% in the Bay Area. It's less than 0.5% in California. And so it seems like people who are getting on ventilators are getting off of them. Now, of course, when you look at the situation in New York, where they may not have the resources, and they have larger numbers of people, but even in that setting, you look at the number of people who are dying, it's just that we get confused because we've never experienced anything like this, to see so many people infected. In fact, I often wonder if we track the common cold, would that send shockwaves through us when we look at the number of people every year who get a cold, but not everybody dies, or if they do, it's not reported on a regular basis.
Awesome. Thank you. We have one more coming in. Have you seen remission of COVID at UCSF specifically?
Yes, we have. Yes, we have. We've had people go home from here and do just as well as, again, some of the folks I named earlier, some of the celebrities that went home, and they're just kind of waiting for it to pass. And so, yes, we have seen. In fact, even even the report of people who have waited to the last minute to come in and got really sick for a moment, we've seen some of them turn around, get discharged from the medical center.
Awesome.
But sorry, Brian, I'm just talking, but some of what we're seeing is that we were able to reduce this curve enough. So what happens, you reach a tipping point where when you get overloaded, I mean, you're at UCSF, you're getting kind of world-class, the best of care. And when you can have all the doctors and yourself and everyone else working on somebody, then you're going to get 100% people being okay. Yet if you get that tip where you guys are overstressed, then, real quickly kind of things go bad. So,
yes. Yes, and really, thank you for mentioning that, Nick. That is extremely important, because some of the places where you see some of the worst outcomes are the places that are overwhelmed, where the resources are not there, where you have individuals who are disenfranchised. Those are the things that you will definitely see. I'll just use Detroit as an example. I mean, you look at the number of cases there and the number of deaths, but then you look at some other states that compare. What is the difference? It's access to healthcare. It's going in and seeking help in a timely fashion.
Okay.
Brian, do you like it? Are you feeling fulfilled as is this kind of one of the things that you kind of live for, being able to do this, or are you glad that you went into respiratory therapy, or maybe not so glad now with this happening?
Oh, listen, let me tell you something, Dr. Cap. I am an adrenaline junkie. If it was a new roller coaster and had the steepest fall, I wanted to be the first in line. So this, to me, I want to be the first in line. I was thinking maybe I should start thinking about retiring, but now I actually want to go to New York and be able to help out there. Now, having said that, because I was talking to a reporter from KQED who I don't think is going to publicize my interview, because I didn't give enough sensationalism. I didn't talk about the fact that, oh my God, as healthcare workers, we're all afraid and we're scared and we're overwhelmed and we don't know if we're going to go home and wake up the next morning with COVID-19. These are the things I know she wanted to hear from me, but the fact that, my posture is one of relaxed but concerned, one of feeling like I was very well prepared. At your alma mater, I did my respiratory care training right there at Skyline College, and I felt like I was prepared for this moment. This is the moment that I have been waiting for, and the fact that I'm now on the research side after so many years is not only am I able to participate in the management of patients who come in with COVID-19 from a respiratory care perspective, I can actually do some basic science research and understand the natural history and the pathophysiology and pathogenesis, and even now not just epidemiology, but functional genomics of these things. It just makes it so much more exciting.
I have one quick final question, and this kind of speaks to the research and information. With all types of news and information that's being thrown out there, is there a resource that you would recommend that would present facts as facts are for any of us that are kind of in this current situation and trying to wrap our minds around this pandemic? Is there a resource that you recommend?
Yes, I do. And for the same reason why your professors tell you beware of going and getting all your information for your papers off the internet, because there is so much untruths related to COVID-19 out there in the media, in the internet. I strongly recommend going to peer-reviewed journals. And the journals that you might want to consider are journals like the New England Journal of Medicine, the American Journal for Respiratory and Critical Care Medicine, Lancet, right? All these medical and scientific journals are going to give you the true facts. And then somehow it gets perverted and distorted when it ends up on the internet or in the news.
Actually, can I put, Brian, I'll put another kick in for a couple other places. If you're interested in podcast, there's one I particularly like, This Week in Virology. Talks about the viruses on there. And then also the Nature podcast. Nature is, it's not as prestigious as JAMA, but it's kind of up there. But
let me tell you, Nature, let me tell you, Dr. Cap, that is the two most prestigious journals in the world are journals like Nature and Cell. Those are the most prestigious. In fact, the other journals that I named that are basically more healthcare practitioner specific, they actually will cite evidence and cite work done in those journals. So that's an excellent resource.
But Nature does once a week. They do a cap up on kind of what's going on in science for the COVID-19.
Yes, and those are your credible resources. They're going to tell you the truth, because to get published in there is not very easy. I was with the group and we tried to get published in Nature and Cell. We got rejected, so we send it to the New England Journal of Medicine. Or if we don't get it there, if we don't get accepted there, we send it to JAMA. So no, that was very well stated.
All right. Is there anyone else?
Looks like chat's pretty silent in terms of questions. Also, out of respect for everyone's time, it's about 5:32 at the moment. And so I'd like to just go ahead and take the initiative in thanking Brian for sharing his time with us for today and presenting everything that he had to present regarding our current COVID-19 circumstance. Really appreciate it. Is there any way that we can include your contact information if anyone has any lasting questions from Science in Action?
I would be happy for you to share that. I'm right there on the smccd.edu. Daniel B., that's me. You can reach out to me anytime now. I have to tell you, working with some of these engineering groups, I mean, believe it or not, I'm working with 3 groups in addition to trying to set policy here in the hospital. And I am still teaching students on Zoom. I'm learning how to navigate that, becoming an expert. I think it's the coolest thing ever done. And so I may not get back to you right away, but usually give me about at least a 48-hour turnaround if it's in the week, not the weekend, and I'll get back to you. Jing, I see you on there. We got a project we're supposed to be working on, and now you see we're sheltered in place. So we got to talk about that. I think there's some cool things we'll be able to do collaboratively, as we talked about on this session.
That would be great.
All right, Brian, you're one of my heroes. Thank you for being there and doing that. And it's wonderful. So
thank you for having me. When we're back in class, anybody who wants to kind of get an idea what respiratory care practitioners do, I have an open class policy. You don't need to call me ahead of time. Just come in and sit down, and I might even include you in part of the discussion if you like. So come on in and see what a respiratory care practitioner learns and what we do, and we'll be happy to host you.
Thank you.
All right, everybody.